Hi everyone, welcome to the 2022 National APAMSA Radiology Bootcamp hosted by our lovely residents and alumni. The first thing I want to address is using the chat box function to ask questions. Because we have 2 hours and we have a lot of information to cover, we want to ask you guys to refrain from unmuting yourself to ask questions and instead type your question in the chat box instead. And while the presenting resident is speaking, the remaining 2 non-presenting residents will answer your questions in the chat box. If you are an audience member and you want to answer a question from your peer, please announce your name, your school, and your year of training before answering this question. So I'm Victoria Shi. I'm on the APAMSA National Board as Alumni Co-Director. I'm from Millburn, New Jersey, and I'm currently a second-year medical student at the University of Missouri, Kansas City School of Medicine. Outside of school, I love going to coffee shops and different restaurants. I love hiking, nature, and outdoor activities, and going to the gym. First up, we have Dr. Jennifer Huang. She's from Chapel Hill, North Carolina. She did her training in Duke University and Vanderbilt University School of Medicine. She's currently a PGY4 diagnostic radiology resident at Vanderbilt, and she'll be a future abdominal imaging fellow at Brigham. Outside of work, Jennifer loves running, board games, and puzzles, and trying to be good at trivia, and also petting other people's dogs. We have Dr. Ying Hu from Toronto, Canada. She did her training at Wellesley College and also the Charité University Hospital in Berlin and University of Maryland School of Medicine. She's a PGY2 diagnostic radiology at University of Pittsburgh Medical Center. Outside of work, Ying loves podcasts, Peloton, and analog photography, and also discussing issues related to diversity, equity, and inclusion. Last but not least, we have Dr. John Malou from Gainesville, Florida. He did his training at University of Pennsylvania and Case Western School of Medicine. He's a PGY4 diagnostic radiology at UCLA. And outside of work, John loves the NBA and Lakers, and also KBBQ and all-you-can-eat sushi. Thank you to our wonderful national board leaders who made today's event possible. And before we get started, here is an overview of the different topics that'll be covered today. I'll leave this up for about 30 seconds so you guys can all be familiar before we begin. Okay, let's get started now, guys.
All right, hello everyone. So excited that you guys are all here today. We're gonna have a lot of fun. Hope you can see my screen that I've started sharing. So we'll just get on started. The first is etiquette. So assuming that our audience right here are sub-Is, interns who may or may not be going into radiology. So I just wanna touch upon before we get started about what is important information that you can share with us so then we can help you answer your question. Okay, so the first thing, please include a clinical indication. If there's one thing and one thing only you take away from this talk is to please include a clinical indication. The reason why is it helps us to protocol studies and to look for specific pathology, look for specific complications, and provide an informed differential to best answer your question. And it also saves us time chart digging and calling the ordering physicians to clarify what exactly they're concerned about. And we can get to the other studies that you guys have ordered. And if you have no idea, it's completely okay. Just say so. I know there have been times when we have like ICU patients who are just extremely sick and we aren't sure what's going on and we pan scan them, that's fine. You just specify what you do know and what you don't know. So these are 2 real indications that I've gotten on studies that I've read. As you can tell, an indication like clinic visit doesn't tell me anything. And the note also didn't even tell me why they were ordering the imaging. Whereas something like this, abdominal pain status post, like PTC exchange, that can be very helpful. And then as with all consults, be prepared before you call. So identify yourself, provide an MRN. Patient X is a one-liner, and then one question to you is whatever your specific clinical question is. So, hello, I'm Joe Schmo of neurosurgery calling about a patient's spine MRI from this morning. Would you be able to look at it? Their MRI is blah, blah, blah. They're a 72-year-old with metastatic lung cancer, history of lumbar fusion, IV drug use who developed acute onset lower extremity weakness and incontinence. We are concerned about whether they have an abscess or spinal met that's impinging on their cord. And that way we can look at it and answer your specific question faster and look for any specific complications related to the pertinent medical history that you shared with us. And another thing is to please share your name and title when radiology calls. I know it's kind of annoying for you and also for us, but when we have critical findings, we do have to communicate it with the patient's primary team or the ordering physician and document it in the report for patient safety. All right, great. So moving on to pre-medications, how to avoid rapids in the scanner. You don't want that, we don't want that either. So to start with, just have a little question. I don't have a poll, but just answer in your head, or you can type in the chat if you want. So of this list, who is at risk of severe reactions to iodinated contrast? So someone with history of shellfish or seafood allergy, hypersensitivity to iodine-containing compounds, multiple allergies, so on. Just give you a second. Okay, so red is the one that you should pre-medicate for. So if a patient has a history of prior severe or life-threatening reaction to iodinated contrast, which is the contrast that we use for CT scans, then you do need to pre-medicate for that to try to decrease the likelihood of a severe, the incidence of like a severe life-threatening reaction from happening, something like anaphylaxis or like laryngeal edema, that sort of thing. But then things such as shellfish or seafood allergy, hypersensitivity to betadine, those are myths. It's totally okay to give patients iodine-containing contrast. And if they have a severe reaction to gadolinium-based contrast in the past, which is the contrast that we use for MRI, it's okay for you to give contrast for CTs, because there are two different classes of contrast agents and there's not going to be cross-reactivity. But there may be some institution-dependent policies for what you can or cannot do, but in general, it's okay to give one even if they've had a reaction to a different thing. There's an increased risk compared to the average population of having reaction, but it's not like a contraindication. And then what we have here, which is in yellow, patients with a history of asthma or multiple allergies, they're maybe 2 times more than the average person to have a reaction to iodinated contrast, but you should just be aware of it and you don't have to pre-medicate it, and it should not it should not be a reason for you to withhold contrast if you need that to answer the question. So how do we pre-medicate? There are 3 different regimens that we can use here, basically using a steroid and a Benadryl. And most of these are outpatient. As you can see, it's with PO at like 12 hours, 2 hours beforehand, and then 1 hour beforehand. And there's also for like more urgent cases, what you can give with IV. If you have any questions about specific scenarios, alternative regimens, or you want to look at the evidence yourself about what supports these recommendations, there's a 130-page document called the ACR Manual on Contrast Media that details this more extensively, so you can definitely check that out. All right, so before ordering a contrast study, the things you have to determine are, first, find out if they have a history of a contrast reaction. What was the contrast that they had reaction to? Was it iodine-based or gadolinium-based? And then what was their reaction? Was it severe or life-threatening, or did they just have a little itch? And will this, as with all studies, the question you always have to ask is, will this study actually give me more information or change patient management, or is it just utilizing healthcare money and not actually helping anyone? And if this study is indicated, is IV contrast necessary to answer the clinical questions? And Jennifer and I will touch upon when contrast would be helpful for chest and abdominal imaging. And of course, considering if the benefits of the exam outweigh the risk, because you need to consider not just the acute risks, such as like having a severe reaction, but also with an AKI, and also potential for developing like nephrogenic fibrosis in the future if you have like underlying renal issues. Great, so now that we've gone pre-medication, out of the way, we can get to the real fun stuff. So this is going to be our approach to chest radiographs. So our goal here today is to have fun and learn some things. And I'm going to have like a core concept takeaway that I want you guys to keep with, take away for each topic. So it should be pretty straightforward and easy to remember. So we're just going to start with the basic concepts of how images are formed. Not going to dive into the physics. That is not important for the layperson, but essentially you have an X-ray source that shoots photons out against a patient. Right now, this patient is standing in PA view. I'll talk about that in a second. And it hits the image detector. If there's something blocking the photons from hitting the image detector, such as if you have bones, then you'll end up, like, the photons won't hit the image detector, and you end up with 4 possible densities. So you have air, fat, soft tissue, and bone. So if it doesn't hit the detector, that's in the case of bone, then the picture is white. And then if it does go through, then it's black. So air, and then fat and soft tissues, you can imagine, are in the middle. So we have an example of a chest radiograph here where you can see that in action. So you can see the bones here are bright, and the liver, the heart, all that soft tissue is more like the soft tissue density. You have some fat around the edges, like at the soft tissue of the body. And then if you're wondering why the lungs aren't completely black, it's because, remember, the lungs, it's not just air, it's like tissue that's holding the air. So that's why it's not completely black. Great, so the first steps for any imaging, there are 4 W's. You wanna know who, what, when, and why. So check the top of the study, is this the correct patient? Like, is the name correct? Is the MRI correct? Before you start reading, because there have been mixes in the past. So correct patient, what is their pertinent medical history? And then what type of study do you have? Is it a chest X-ray? Is it an CT, ultrasound, MRI? And what type of views do you have, or what type of projections? So is it APPA, lateral? And do you have any priors that you can compare it to? Because priors are your best friend, because you can see the acuity of any changes, and see in terms of why, it's what is the study indication. And that's where it comes in really helpful when the ordering providers specify what they're exactly concerned about. So if we talk about the different projections that we have, so basically the name of the projection is the direction that the X-ray beam goes towards. So a PA film would be going from the posterior to anterior of the patient's body. So that's typically done in an outpatient setting, so the patient's ambulatory. And then you have AP, which is usually how you have with the portables, and you can have that in like supine or semi-erect. So the direction of the X-ray beam goes from anterior to posterior. So things to note with that is, in the ambulatory setting, if you've ever seen an X-ray done, the patients are like pretty far from the X-ray source. They're around like 72 inches, and they're pressed right up against the image detector. Whereas when you're in like the hospital setting, patients are a lot sicker, you're taking it in the room, you're not able to have the X-ray source as high up. So it's usually around like 40 inches or so, and it's going anterior to posterior, so the heart is further away from the image detector. So hopefully this diagram can show you that you can have differences in the heart size just based on these 2 things. So in the PA view, the heart may seem like 13 centimeters, and that's closer to the real size, because if you've played with shadows before, you know, if your hand is like closer to like the wall, then like it looks more like the size of your hands, and it's further away and it's closer to the light source, you're going to have like big monsters on the wall. So in the case of patients who are in portables, the heart can seem abnormally magnified even when it's really not. So this is a case just from Radiopedia of the same patient taken one day apart. Literally nothing changed in their clinical status or their management. But the top one was taken in the PA view, and this one was taken AP. And you can see that the heart looks abnormally enlarged. And you can also imagine that maybe there's a little atelectasis or pneumonia at the lung bases. And this is a meme from my friend, Emil. To find a difference between these 2 pictures, they're the same picture. You just need to be aware of the shortcomings so you don't think that they're different. So when you start looking at the film, that's why it's important to peep your film for technical adequacy. So giving you a handy dandy mnemonic. So PEEP is penetration, inspiration, position, which includes angulation, rotation, and magnification. So we'll go over each of these individually, but essentially, if all of these things are perfect, which is usually in the case of a PA film, then you can know that you have the most reproducible like imaging that you can compare. So the first thing is whether or not you have adequate penetration. So that is whether or not you can see the spine through the heart. So you can see all the vertebral bodies here, and the heart is right there. And there are cases where if you're, when I say penetration, it's just about like the X-ray beam hitting the image detector. Like if you send out, don't send out enough X-ray like photons, then the image is going to be underpenetrated. If you send out too much, it's going to be overpenetrated. You're just going straight through. And the issues with underpenetration is, look, you can barely make out any of these structures. Clearly, you don't see the spine through the heart, and the left hemidiaphragm is also completely obscured. So the reasons why this is bad is that it can mimic disease, or it can obscure disease that's like hiding within this area. So this is an example of what ARDS looks like, and you can tell that it can be confusing and look very similar. And then in the case of an overpenetrated foam, you can mistake this as, for example, emphysema, just because the photons are just going all the way through and makes your lungs look a lot more lucent than it really is. Okay, and then next is about whether or not you have adequate inspiration. So what is a good inspiration? It's when you have ideally 10 ribs, 10 posterior ribs that you count above the diaphragm, but we can settle for 8 to 9, especially in the inpatient setting. So I've labeled these for you. So we're looking at these posterior ribs back here in this like cartoon picture of the ribs. And basically you start counting by looking at like the transverse process of the first thoracic vertebrae. And then you just start counting this back stuff. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So that's good inspiration. So how do you tell it's the posterior ribs and not the anterior ribs? The posterior ribs are more horizontal appearing. They're going to be more prominent as opposed to if you look at the anterior ribs. I'm not sure if you can see my mouse, but they're like the anterior ribs are a lot more sloped downwards and they're a lot fainter. And you can also tell just which are the posterior ribs by just tracing it back to the vertebral body. And just one thing to be careful of is oftentimes the second posterior rib overlaps the first posterior rib. So don't accidentally miscount. So this is a case of a suboptimal inspiration. So this patient, 1, 2, 3, 4, 5, 6, 7 ribs above the diaphragm. So it's suboptimal. And you can see that you have the illusion that you have like crowded lung markings at the base, and it looks like there's aspiration. Maybe there's even pneumonia on both sides. The heart looks massive, but it's an inadequate inspiration, so hard to tell. Right, next we talk about adequate position, so specifically angulation. So we are focusing on this part here, which is the head of the clavicle. So the clavicles are S-shaped and they should superimpose onto the 3rd or 4th ribs. And the reason why that matters is because if patients are really sick in the hospital and they're not able to get like the ideal view where the X-ray source is directly penetrating like perpendicular to the patient's torso, instead it's sort of taken at an angle. That's what we call like an apical lordotic view, which is what you see in the middle here. Then you can see that structures that are more anterior in the chest are going to project much higher up compared to structures that are like further back. And it seems like it's located higher up than it really is. So this is an example of an apical lordotic view. How do you tell? So we can just compare this to our good radiograph on the left. So in the apical lordotic view, the clavicles project like above the first rib. You see it basically above the lung apices, and they're straight as opposed to being S-shaped. The heart looks weird and the left hemidiaphragm are obscured. Okay, and the next thing is rotation. So the spinous process is equidistant to the medial ends of the clavicle, which makes sense because you're just shooting the X-ray straight through. So this is what happens when the patient is angulated to the right or to the left. Okay, so the patient is turned a bit more to the right, then you can see that the head of the clavicle on the left is brought closer towards like the spinous process, because remember this is a 2-dimensional projection of like a 3-dimensional like structures, and then it's the opposite in the case of if the patient is turned to the left. So how can this be confusing is this patient is markedly rotated to the right. But if you did not think of this and didn't look at like, well, it's hard to see on this picture, but if you didn't consider this, you might think, oh, they have like a mediastinal mass, or they might have like a mediastinal hematoma, or there's something severely wrong, but it's really just rotation. And then lastly, and we already talked about this, I won't go over it again, but the AP view can magnify the heart. So just remember, in short, not all radiographs are created equal. So just always remember to peep your film to avoid being misled. Okay, and then now we're gonna go over some basic anatomy. So I've labeled the cardiac chambers here for you guys. So basically we have the superior vena cava up here, and then the right heart border is essentially going to be the right atrium on the frontal view. And then you're gonna see the left ventricle outlining most of the left heart border. And then you may or may not, the left atrial appendage may also form part of that edge, especially if it's enlarged, whereas in the lateral view, the chambers that form the heart borders will now be the right ventricle, oops, sorry, I mislabeled that, right ventricle at the top, and then left ventricle at the bottom, and then left atrium also at the bottom. And then, so this is what a CT looks like, just to prove it to you. So right atrium, left ventricle, and then in the lateral view, you see the left ventricle and then the left atrium. So then just a side note is when you have ventricular obstruction, so you have any like valvular stenosis, the first things that's going to happen is hypertrophy of the ventricles. So you're not going to see like dilatation of the heart chambers until much later. So just because you don't see dilatation doesn't mean that you don't have some type of obstructive process going on. And most of the you have most marked dilatation when you have issues with volume overload than with pressure overload. So when you have regurgitation rather than stenosis. And then cardiomegaly, if the heart is enlarged, usually it's because the ventricles are enlarged, not necessarily the atria. And of course, just to know how big is the heart supposed to be on this radiograph. We don't actually measure it, but just know that approximately it should take up less than 50% of the width of the thorax. And these are the other things that are labeled. So we have the trachea, which is this loosened structure in the middle above the SVC, and then we see the clavicle, the straight, and then the scapula, and we see the hemidiaphragms. The cardiophrenic angles are sort of the border of the heart medially, and then at the side we have the costophrenic angles, which should be nice and sharp, and then we can sort of make out a stomach bubble here, and this is the aortic knob. On the lateral view, you see sharp costophrenic angles, which is how it should be, and the vertebral body should be you should see the vertebral end plates of each vertebral body should be parallel and straight and preserved. So just something not to miss in case someone has like a fracture there or just some lesion. And then people talk about hyla. So there's the left hilum and the right hilum. What exactly are they talking about? Really, it's the pulmonary arteries because the pulmonary veins are more like horizontal in appearance, and the bronchi, you don't really make out super well just because they're like thin wall structures that are containing air and air against air. You can't really differentiate. So when people talk about hyla, they're referring to the pulmonary arteries. And you can see on the lateral view is just sort of that middle section there. And people say it looks like little fingers. Sometimes you may see the fingers, sometimes you may not, so it's not anything specific. The left hilum is going to be higher than the right hilum, I think in like 97% of patients. And then in 3% of patients, they're the same height. So the right hilum should never be higher than the left. So if it is, you know, things have moved around. And then drawn two circles here, just because I want you to pay attention to the vessels, just the normal vascularity of the lungs. You're gonna see that at the lower lung zones, that the vessels are just more prominent and larger than it is in the top. And that'll be relevant later because, you know, when you're congested, then this may be reversed, or you'll see it a lot more prominence in the upper lung zones. And then we talk about positive things, but we also need to talk about negative space. So two important negative spaces are the retrosternal space and the retrocardiac space that you can see in the lateral view. So this should be clear, the retrosternal space. If it's filled in, you got to make sure that you're not looking at the arm that's just like not elevated as it should be. But if it's filled in, you would be concerned about like an anterior mediastinal mass. And then if the retrocardiac space is filled in, you might think that maybe the left atrium is enlarged or something. Another thing to pay attention to is something called a spine sign, which is as you go down, you have just less soft tissue in general. So then this, it should get darker as you go down the vertebral bodies because like the photons are able to penetrate through better. But if it doesn't get darker, there's like some opacity there, then you'd be concerned that maybe you have like a pneumonia there or some mass in that area that shouldn't be there. And then I just drew out the fissures here. You don't actually see it, like I'll take off my drawing, but you don't see the fissures on a normal chest radiograph because you shouldn't. It's like very pencil thin. The only time you see it is if it's thickened, if it's filled with fluid, or if maybe you have like thickening from like malignancy. And then I've labeled here the left and right hemidiaphragm on the lateral view because I think that's helpful to sort of localize pathology. So how do you tell which one is which? So your heart sits on top, is on like your left side, right? So if your heart is sitting on top of your left hemidiaphragm, it like soft tissue next to soft tissue, you're not going to be able to see the border between them. So the left side will sort of abruptly end there, whereas the right side doesn't have any equivalent on that side. So you should be able to see it, that line go all the way straight through. So if I just remove that line, you can see here, this line goes all the way straight through to the front. That's how you know it's the right hemidiaphragm. And then the left sort of ends abruptly over there. And then the things I've circled here are just areas that things tend to be missed because I'll talk about a search pattern in a second, but you always need to make sure that you're checking the apex because things can be hidden there, and also like the hilar region, the retrocardiac region, and also under the diaphragm, under the dome of the diaphragm. Because remember, if you see on the lateral, the front part of the diaphragm is like higher than the back, so things can be hidden back here and you may not be aware if you're not looking for it. So talking about a systematic approach. So there are different approaches. I think in general, radiologists, we all just say it doesn't matter what approach you use as long as you're making sure that you're hitting everything and you're doing the exact same thing every single time to make sure you're not missing anything. I know a lot of internists love this ABCDEFG configuration, which is like airways, bone/body, cardiac diaphragms, effusions, lung fields, great vessels. If that works for you, go for it. Another approach that you can take is like out to in or in to out. This is the way that I personally prefer, just because you don't have to memorize anything. You just have to like move your eyes in a way that makes sense. So you just sort of start out by searching underneath the diaphragm to see if there's any abnormalities. You want to make sure you definitely don't miss like a pneumoperitoneum, like free air under the diaphragm. So you just search under that area, and then afterwards you move to the right, and then you go up and down. So you check the soft tissues of the body, you check the ribs, you check the clavicles and the bones. And then after you've gone there, then we'll move to the second row, and you go downwards. You check the airways, so the trachea and the like main stem bronchi, and then you circle back up and check the rest of the mediastinum, like the size of the heart, the hyla, to see whether or not like this vascular pedicle is widened and so on. And then you search each lung field, and then both lung fields for symmetry. So I think that way makes a lot of sense, but whichever way works for you is the one that you should do. And then if we have the lateral view, same thing. You sort of check the soft tissue and bones outside first, check the bottom, like subdiaphragmatic, follow up the spine, come down the front, and then follow like the heart and mediastinal structures, and then check the lungs. Because you know it's a chest x-ray, you're never gonna forget the lungs. That's why we save the lungs for the last. But then you may forget to check like under the diaphragm or the bones if you don't start with that first. Okay, so great. Now that we know the structures and we have somewhat of a search pattern, we can work on localizing pathology. So the core concept that I want you to take away from this is something called the silhouette sign, which I will explain. So I don't have a poll up, but you can answer in your head or in the chat. So I have a picture here, so try to guess where this consolidation is. Is it the left upper lobe or the left lower lobe? And then we actually have lateral, so maybe that will help. And the arrow sign should help as well. So this is the left upper lobe. This is the lingula, where this consolidation is located. So some of you might be looking at me like, how am I supposed to tell that from this frontal radiograph? Like, it's just in the lower half of the lung. So I'll tell you. So this is what the concept of the silhouette sign is. And so if you have two objects of the same radiographic density touching each other, the edge between them disappears. So this is my very basic diagram of the heart and the diaphragm. So if you have a consolidation that's like right here, you can see it, it's surrounded by air. But if you have a consolidation right here, what happens? The heart border is now no longer clear. And then if you have a consolidation right here, of course, none of it will ever be that well defined, but the left hemidiaphragm will no longer be as like well demarcated as it should be. So label diagram here of like what you should think should be the lobe that's involved if it's unclear in each area. So right lower lobe, if the right hemidiaphragm is obscured, left lower lobe is the left hemidiaphragm is obscured. If the left heart border is obscured, think the lingula of the left upper lobe. If it's the right heart border is obscured, the medial aspect of the right middle lobe. And then if it's like something up here, it can be left upper lobe. So I'll go through a few questions now to test your understanding. So just sort of answer in your head. Oops, that gave it away. Okay, well, this first one is, what do you think is involved? So what is obscured in this picture? So it's sort of cut off, but you can see that the left heart border is not very well distinguished, just as in our last picture. So what's involved is the lingula of the left upper lobe. And this is the CT proof for you that this is the lingula of the left upper lobe. And then in this next example, what do you think is obscured in this case? So if you guessed right hemidiaphragm, you're correct. You don't see it well defined as you do on the left side. So that tells you the involved lobe is the right lower lobe. And in this next example, what's obscured here? So you can see the nice left heart border. You can make out the diaphragm here, nothing up here. Looks like there's right heart border you don't see very well. So the involved lobe is the medial aspect of the right middle lobe. There's the proof for you. And then this next one, guess. So once again, left hemidiaphragm, you can see well left heart border. Can't really make out the right heart border. Not sure if I can make out the diaphragm either. So the involved lobe is actually both the right middle lobe and right lower lobe. Remember, more than one thing can be the problem. And this last one, which is fun. So put an arrow on where the abnormality is. So where do you think, one of the arrows is a hint. So where do you guys think the abnormality is? So clearly the left side is okay because there are no arrows there. So on the right side, you would think, well, it seems like it's in the middle of the right lung. So how do I tell what the abnormality is? It's clearly the diaphragm and the right heart border aren't involved. But what you can tell here is you can see where this dashed arrow is. You can make out the minor fissure here, which is a hint, because it tells you that it's actually not involving the right upper or the right middle lobe. It's actually or else you wouldn't see the fissure. If you remember the silhouette sign, it should just be gone. But since it's still well delineated, you know it's a superior segment of the right lower lobe that's involved. Another thing, just to remember, I think what I wrote here, aspiration pneumonia most commonly involves the right lower lobe, but that depends on the position that the aspiration occurred. And the reason why that happens is just because your right main stem bronchus is just more vertical and shorter than the left. Okay, so now we're moving on to classifying parenchymal lung disease. This is more just so you understand the concept of like what we're saying in our reports and what we mean by like, oh, there's like airspace opacities. Okay, so this comes down to the functional unit of the lungs. So basically your lungs, you have like the bronchi and the pulmonary arteries, and they all terminate in these things which are called the secondary pulmonary lobule, which is this collection of these alveolar sacs, which is where gas exchange happens. And each of these pulmonary lobules is surrounded by like supportive tissue, like interlobular septa, which is just like connective tissue, which contains lymphatics and like the pulmonary veins. So why is that important? That's important because this is just a diagram of what that shows, but that's important is because you can think about where the abnormality, like what type of abnormality you have, depending on what's involved. So now you know the main component is like the air spaces, which are the alveolar sacs, and then you have the interstitium, which is the rest. So you might involve one thing, the other thing, or both of the things. Okay, so in the case of airspace disease, think about what you can fill the alveolar sacs with. You might fill it with blood if you have pulmonary hemorrhage. You might fill it with inflammatory stuff if you have pneumonia. You might have like fluid if you're like pulmonary edema and like, or you have like a near drowning event, or you might have like gastric contents in the case of aspiration. So those are all things that will just fill these air spaces. And then you have more chronic stuff, which we don't have to go over. And that is in contrast to if you have thickening of the interstitial, like involvement of the interstitium. So it's not involving the alveolar air sacs per se, but it's just involving like maybe the lymphatics. You have like issues with lymphatic drainage, or in the case of like early heart failure, then you would just have congestion in the supporting tissue. So airspace disease essentially is when you have like fluffy, hazy opacities and they appear to be merging into one another, or they're like fulminant is what we say. You may or may not see air bronchograms because remember, like with the silhouette sign, like your like airways are, you're not going to see them normally unless there's like contrast of some different densities. So if you have a consolidation there, now you're going to see the airways, and that's what we call air bronchograms. So that's what we see in like the top right corner with the little dashed arrow. That's an air bronchogram in this consolidation, which is a pneumonia. And then in the bottom left, the example that we have here is aspiration, which involves the right lower lobe and also actually the left. And then in the middle, we have a case of pulmonary alveolar edema. So that's when you just have too much fluid, and sometimes we describe it as like a bat wing appearance, if you can use your imagination. And then this is a case of diffuse pulmonary hemorrhage on the right. So you can tell that it can all look very similar. So we can't tell what the content of it is. That's why history is very important. But in all cases, it's just like filling up the alveolar sacs. And that's in contrast to interstitial disease, which is not super important for like the regular internist. So just know that there are different types. It can have different patterns. It may be reticular if it looks like nets, or it might be nodular, or a combo of the two, reticular nodular. It may be diffuse, it may be focal. This is a case of like UIP, which is like a usual interstitial pneumonia, and you see a reticular pattern, and you see like honeycombing bronchiectasis. Not super important, just so you know that it's a different thing that happens. All right, so next we move to volume overload. The core concept is just what happens in a flood, and if you can imagine that, then you'll know like the progression of what you would expect to see in different stages of like volume overload. So if you just think about it, like you have rivers, those are like your vessels. If it fills up with fluid, then it gets congested, then you'll see it a lot more prominently if you're like looking from a satellite, and eventually it'll start spilling over into like the land that's next to it, and that's what you might see as like haziness, and eventually when you have like way too much fluid, like everything just becomes like water. So these are the three stages. So you have redistribution, then interstitial edema, and then alveolar edema. So redistribution is basically when you have cephalization. So remember with the anatomy picture I showed you, in the lower lung zones, the vessels should not be as prominent as they are at the vessels at the top are not as prominent as they are at the bottom. But when you have like a lot more fluid in your vasculature, then it's just going to be a lot more prominent. So in this case on the left, this is normal. And then in the first picture with where the blue arrow is pointing to, and then in the second half of the picture, this is when the patient is volume overloaded. You see that the vessels are a lot more prominent in these upper lung zones than they should be. And what this red arrow is pointing at is what we call a broad vascular pedicle. Vascular pedicle is just referring to like this area that is like your aorta plus your SVC that you see in the little cartoon on the left. And that's relevant in that like it sort of gives you a hint of your like intravascular volume, because if you're really volume overloaded, your SVC is going to be more like it's just going to be more distended, and then your vascular pedicle may be wider. And that is like a way that you could differentiate whether it's like a cardiac or non-cardiac cause etiology for your like volume overload. And another thing you would see is, of course, the heart would be enlarged. So that's when you see cardiomegaly. This heart is clearly more than 50% of the width of the thorax. And then this is not particularly specific, but you may see like the artery to bronchial ratio is like enlarged. So the arrow is pointing there, like the artery should not be bigger than like the bronchioles, but clearly this like white stuff, like the white circle, which is the artery, is bigger than the bronchial. So that is another hint for you. And then the next step, you have, you go from redistribution to interstitial edema. So now you have like a ton of fluid in your vessels. It's starting to spill out. And that's when you see things like peribronchial cuffing, which we see here. So peribronchial cuffing is basically when it just starts filling, the like fluid starts spilling out into the surrounding tissues. So then it sort of thickens the border around the bronchioles. So then that's what we call it, just ends up being like a haziness around the bronchioles. And that's what we see here. In the first picture, you may see curly bee lines, which are just these like little straight lines along the edges of the lungs, because that's the intralobular septa, which we talked about as part of the secondary pulmonary lobule. Like each functional unit, those septa are now more prominent. It's like filled with fluid, and that's what the curly bee lines are. And then you may see fluid in the fissures, which is what we see in this third picture. So I told you in normal chest radiograph, you should not see it. So if you see it, they probably have a little extra fluid than they should. And you may also see a pleural effusion. And then finally, progression, everything just spills out everywhere and into the air sacs. So now it's gone from the interstitium to the alveolar sac. So now what we have is alveolar edema, and that's when you get like consolidations, and you might even see air bronchograms. So the arrows are pointing at some pertinent things to pay attention to. So you see it's like hazy opacities everywhere. That's the alveolar edema. You might even make out a little bit of these air bronchograms where like the yellow arrows are. They have a little pleural effusion at the left side, and then you can see that the heart is enlarged, so it's cardiomegaly. But after diuresis, everything just clears up. And that's heart failure. All right, next, so moving on to effusion. So the core concept of this is all you have to know is that basically it's water in a bag, and where the water will go depends on how you're positioned. So essentially, if you remember, the lungs is covered by visceral pleura, and then there's the parietal pleura that's abuts it, and there's a like sort of a potential space, there's just a pleural space in between it that does contain a little bit of fluid, so then it can sort of slide along each other. And this pleural space can fill with stuff, and depending what stuff fills it, you can give it different names. So if it's filled with air, or there's some extra air in it, then you would call it pneumothorax. If it's serous fluid, like it would be a pleural effusion. Blood, hemothorax, purulent fluid, empyema. If there's like fat and triglycerides, it would be like a chylothorax. If you have mixed air and fluid, it would be a hydropneumothorax. So this is a cartoon diagram of what happens in an effusion. This is a patient who is upright. I drew their two lungs here for you so you can see their positioning. So basically when you start out, you accumulating fluid, where does it again accumulate? It's like at the base, because it's just a tank of water. It's a bag of water. So you'll see that, and you might even see something called a meniscus sign, and that just has to do with like the elastic recoil of the lungs. It just so happens that like the pleural fluid along the lateral aspect of the lungs will be pulled up more than like the medial aspect, and that's why you see a sort of little meniscus. And that's what that looks like. So this is what a sharp costophrenic angle looks like. And that's what the meniscus sign is when you have a pleural effusion. Because you should normally see like like you can see your lungs go all the way nicely out to the edge in the normal one. And sometimes you might just have a teeny pleural effusion, but another hint you might have is like you have filling in of the fissures, as I mentioned, which you normally should not see. And then you can accumulate more pleural effusion. I've gone phone calls about this before. Don't ask radiology to measure the volume of the effusion. I can't tell you. And I also cannot tell you if it's transudative or exudative. You need to tap that. But just in general, you can know that you need approximately, to accumulate approximately like 300 milliliters of fluid in order to blunt the lateral costophrenic angles on your frontal view. On the lateral view, since you're seeing the whole like side of the lung, you only need like 75 milliliters to start seeing some of that blunting. Okay. Oh, and then, so I forgot to mention, so sort of the progression of the fusion. So the way it starts accumulating, remember that the front of the diaphragm is like higher than the back. So then you can start accumulating effusions. First off, it's like always starts at subpulmonic, just basically meaning it's like sort of hidden to the view because it's at like the back side, I guess. You may not see it and it can be missed. So just, this is examples of like right subpulmonic effusion and like the left subpulmonic effusion. And it's hard to tell, right? You're like, is the diaphragm just elevated? But you can see here that there's a meniscus sign, and the diaphragm being elevated, of course, is a hint for you. And on the lateral view, you see it sort of like slopes this way. You're like, is that a diaphragm? But then all of a sudden it like sharply slopes anteriorly to the chest because it's sort of following the path of the fissure. And that's how you know you probably have a subpulmonic effusion. And that's the same thing with the left side. Another hint that you can have is just that, okay, the left hemidiaphragm here is elevated, but is it just the hemidiaphragm's elevated, or do we have a subpulmonic effusion? So you can tell with this black arrow here, it's showing you that the distance between the gastric bubble is further than you would expect. None of these are particularly like sensitive, but if you see it, it can be a hint as to what you're looking at. And then of course, things will look different if you're supine. So if you're laying flat, like fluid accumulates, will just like lay there as opposed to sort of accumulating in a corner like it does when you're standing or semi-erect. So then instead of having a nice well-defined like fluid line, you end up just, the whole lung looks a lot hazier than you expect. So this is an example of the same patient who is with images that are taken minutes apart. So this is when they're laying completely supine, and the second image is when they're laying a bit more in an upright position. And it looks like on the picture on the right that like their effusion improved, right? But this was literally taken minutes apart and it didn't improve, it just moved. So that's just something you have to be aware of, like acquisition of the image actually impacts your interpretation quite a bit. All right, next, moving on to concept of atelectasis. So the core concept here is something that collapses will pull the things around it. So what is atelectasis? Atelectasis is the loss of lung volumes, i.e. the collapse of something, of the lung due to decreased aeration. So the main ones you're gonna encounter are obstructive and passive. So what does that mean? Passive atelectasis is basically when you have something else that's in the thorax taking up space, whether that's air or like an effusion, and it's sort of passively pushing on the lung so it's collapsing. That's what passive atelectasis is. And the second thing that you can have is obstructive. Obstructive atelectasis is when you have something that's blocking the airways, some part of the airways. So then the air in the alveolar sacs will have gotten absorbed into like the blood vessels, the like pulmonary capillaries. And then now because it's like entrance is blocked into those alveolar sacs, you can't fill it up with air. And so you end up, that part of the lung like collapses. So that can happen if you have like an obstructive mass there, like a cancer. So they have the same effect of collapsing the lung, but it's a different pathology and a different management. So this is just a schematic from core radiology of like different like lobar collapse patterns. So this is maybe overwhelming, but all you have to know is like when things collapse, everything else is going to be pulled with it. So for example, if you look at like the right upper lobe, like the pink section, if that collapses, so it like brings in, then everything else, like the right middle lobe and right lower lobe, are going to be brought up towards it. And same thing, if you have like the left lower lobe that collapses, okay, well the left upper lobe is going to get pulled down. So it all makes sense. So there are direct signs that you can look for, like if your fissures are displaced, or you see like vascular crowding, like the vessels are a lot like more crowded than they should be because they've been like collapsed. Or you can look for indirect signs, like if you have an elevated diaphragm because it's also getting pulled up, displaced hilum because it's getting pulled somewhere. You might see rib crowding on the side with volume loss. The mediastinum may be shifted. You might get like compensatory overinflation of adjacent or contralateral lobes. So I'm just going to run through some examples after this question. So what is the most likely diagnosis here? Just take a second to take a look at that. What do you think is going on? Do they have pulmonary edema, pneumonia, atelectasis, mediastinal mass, a left apical pneumothorax? Okay, so based on the things that we went over, it doesn't look like they're congested. It doesn't look like there's a focal opacity. The heart borders and the diaphragm are pretty well delineated. The mediastinum is normal in its width. There's no pneumothorax. So the answer is atelectasis. So what part is involved here in the atelectasis? Is it the left upper lobe or the left lower lobe? So you may think it is the left lower lobe because you're like, something's off with that left diaphragm. It's like, seems like it's getting pulled up, but actually the answer is the left upper lobe. And what this is the Lufsical signs. So radiology loves their signs, and this is just one of them. Essentially what happens, and this is just extra proof for you. So essentially what happens in Lufsical sign is that the left upper lobe is collapsed. So if you remember, it collapses if everything else gets pulled up with it. So the left lower lobe gets pulled up. In fact, it has compensatory hyperinflation. So that's, and it's sort of like part of it slides up in between the left upper lobe and the aortic knob. So that's this lucent line that you see at the aortic knob. That's actually part of the lower lobe, like compensatorily hyperinflating. And you can also see the left hemidiaphragm is tented and also just higher than you would expect it to be. And what you can see if you have a lateral film is you can see like the fissure here is like almost vertical. It's like this long straight line here. It's like pulled upwards more than it should be. And also like the anterior retrosternal space seems to be filled in. That's because that's your left upper lobe getting collapsed. And then these other things, you don't have to memorize these. I just want to show you examples of other lobe collapses just so you can have seen it once. So this is what right upper lobe atelectasis looks like. So things are pulled up. It's called a reverse S sign of Golden because typically with upper lobe atelectasis, you should be concerned for some type of underlying malignancy that's causing the obstructive atelectasis. So in the right upper lobe, this yellow, it's like a reverse S, if you can imagine it. The yellow arrow is pointing to part of the S, which is actually an obstructing mass. And then this red arrow is pointing towards the line that is the collapsed right upper lobe. And you can see that nicely in the lateral view. Yep, so mass minor fissure. And then this is what a left lower lobe collapse is. This is a flat waist sign. Don't really understand that name, but essentially the left arrow is pointing to the left heart border, and then the red arrow is pointing to the collapsed left lower lobe. So you see a downward shift of the hilar structures, and it's also causes some flattening of the heart borders, and the heart ends up being a little rotated. And lateral views are actually amazing and totally underrated because if you see the lateral view, it's a lot more clear like what exactly is happening. The left lower lobe is collapsed. This is what right lower lobe collapse does. Essentially same situation as left lower lobe. You see this retrocardiac opacity here. And you can also see in the lateral view, and this yellow arrow here is pointing to the fact that there's been some rib crowding just because everything is getting squished from being pulled downwards. And this is what right middle lobe collapse looks like. So nothing is obviously pulled, like maybe the right hilum is pulled down somewhat, but what you can use here is the silhouette sign. The right heart border is not very clear, so there must be some abnormality there. And the lateral view confirms that. Okay, so how about the case when you have a completely opacified hemithorax? What's your differential? What's going on here? So is it pneumonia? Is it atelectasis? Is it pleural effusion or pneumonectomy? That should be your differential. But how do you differentiate it? Because it looks like it can all be pretty similar. It's just white stuff in half of your chest. So the concept is about pulling versus pushing. Are you collapsing and pulling something, or is something filling the space and pushing things away? So on the left image here, we have what we have is like basically collapse of the whole like left lung. And what happens is when it's collapsed, as I recall, things get pulled towards it. So you see that the trachea is pulled towards it. Whereas in the case of the pleural effusion, now you're filling up the whole right lung, right hemithorax with fluid. So that's essentially going to have a mass effect in pushing stuff out to the other side. So that you have the shift of the mediastinum away from this opacified side, and the heart is like sticking out further than you'd expect it to onto the left. And then this is an example for pneumonia. So with pneumonia, if you have like a massive pneumonia, which involves a lot of your lung, it can also look like this. I think it's pretty rare, but it's just filling your air spaces. Remember, it's like airspace consolidation stuff. So it shouldn't push anything or pull anything. So it should be neutral. And you may make a bronchograms, because remember, it's like concept of silhouette sign, where now the airways are more visible because it's contrasted against filled in tissue. And then this is the final thing in the differential, is when you have post-pneumonectomy, you can see that on post-op day 1, you have the surgical staples. There's no more lung there. The right lung field is like totally hyperlucent. And then 1 year later, eventually the fluid fills up the area, and then the like mediastinum and the left lung are like, oh, look, there's a lot more room here. Let's take up space there. So then they sort of slide over to that side, and you get pulling to the side where the lung was removed. But that one you should be able to differentiate because they will have surgical staples. All right. Next, pneumothorax. The core concept for pneumothorax is that air rises. And if you understand this, you'll know where to look for your pneumothorax. So, quick question here for you guys. Do you see a pneumothorax? I'll give you a second here. Okay. I hope you were not tricked by the brush shadows, because that is not a pneumothorax, but there is indeed a pneumothorax here. In fact, we have a hydropneumothorax. So basically, I know it's probably very hard to see, but this is the like visceral pleura right here. And you can see that it's retracted away from like the wall of the of the hemithorax. And then you can see that there's even if you didn't see that because it's hard to see, you might see this horizontal line across the thorax, and there's nothing that should create the perfectly straight line across there. So if you see that, you would think, oh, there must be an air fluid level, because you need contrast between things to see that line. And that might be the only hint that you have a hydropneumothorax. So how do you tell? So basically what you have to see is that you must clearly demarcate that there's like a visceral pleural line that's separated away from the chest wall, and it will parallel the contour of the chest wall. And the thing that will help you differentiate it from other mimics is that you see that the lung markings, they only go up until the pleura. You don't see any lung markings beyond that. Okay, so if you know this, you'll be able to identify a pneumothorax. So in this case, do you see a pneumothorax here? Is it this thing? No, it doesn't look like it. Looks like there's a pneumothorax here, right? There's like a line going all the way along here. Well, we got a CT. There's nothing there. there's no pneumothorax. So what happened? So what it was is a skin fold. So skin fold, if you just the patient just happens to be laying in a certain way, and it just happens to like recreate this beautiful line across their back, it can look like a pneumothorax. But the way you can differentiate it is just remembering that one definition I gave you, which is you see the clear visceral pleura here. That's a nice, thin, well demarcated, follow it all the way to the edges, and there are no lung markings beyond it. Whereas in this skin fold picture on the left, you can see that it looks like there's lung markings that go beyond that line. So that's how you know that you're just getting tricked. The other traps that you can fall into besides skin fold looking like a pneumothorax. So you could also have the medial edge of the scapula, like on the right side, it looks like it could be a pneumothorax, but if you know the scapula is there, and also if you remember that one rule and just know that usually the pneumothorax will be parallel to the chest wall, you'll know that that's probably not it. And then you may have cases where you think, oh, well, I don't see a visceral pleura line, but it seems to have absent lung markings. So maybe there's a pneumothorax. Well, that's not the rule, because you can get tricked by if patients have bullous disease or cysts in their lungs. So for example, this case here, this patient has a little bulla, may look like an apical pneumothorax, but it's not, it's fine for them. Or in this more dramatic case where this patient has a ginormous bulla, but that's also not a pneumothorax. So just make sure you don't get tricked. So you always need to make sure you see this visceral line and no lung markings beyond it. All right. Is there a pneumothorax in this picture? There's a hint in this picture, which should tell you whether it's a pneumothorax, which is the fact that there's a chest tube. So yes, there is a pneumothorax here. But if there was not a chest tube, the way you would tell is something called the deep sulcus sign. So basically what happens? So if the patient is standing erect or semi-erect, like air will rise, okay? So you're gonna be checking for like pneumothorax at the apices. But if the patient's lying flat, and a lot of like ICU patients will be, the only hint you'll see is this deep sulcus sign, because air is now rising to the highest part of their body, which is, if they're laying flat, it's gonna be like their rib cage area. So, and this anterior aspect. So that's why you get what we call the deep sulcus sign. And then sometimes you may get a question or would like to ask a question to the radiologist of, should I place a chest tube in this? So that's a clinical decision that's based on the patient's hemodynamic status, their clinical status. That's not something that I, as someone who's not seeing the patient, except their imaging, can tell you, unless they have a tension pneumothorax, in which case, yes, please place a chest tube. So how do you tell if there's a tension pneumo? So that's when mediastinal structures are shifted away from the side of the pneumothorax. Remember what I said about pushing and pulling. Is something filling it or something collapsing it? So in the case of tension pneumo, the air, like there's too much air in there that's gonna push everything to the other side. So this is an example of that. So we have a ginormous tension pneumo on the left. You can see here the asterisk, that's where you have like some deep sulcus sign, and you have the pushing of the mediastinal structures over to the right side, because the heart should not be sitting like all the way far out to this side, right? You may also see a flattened hemidiaphragm, or the heart contour may be flattened on the side that's under tension. Great. So we're reaching the end here. So we have PE. The core concept for this is that findings are non-specific. So what do you think the percentage of chest x-rays are that are normal in the case of an acute PE? Is it like 5%? Are they 20%, 80%? Are all of them normal? Will chest x-rays even tell me anything? So the answer is, the numbers approximately 10 to 25% is what I've seen can be normal. So you may have a completely normal chest x-ray, but they might still have a PE. Doesn't mean you shouldn't get a chest x-ray, because I think it's a very reasonable part of workup for chest pain or dyspnea. You may or may not see a pleural effusion, but that's very non-specific. Of course, there are some findings in the remaining like 75%. What might you see? You may see some like subsegmental atelectasis. Basically, that's like a segment of your smaller segment of the lung is like collapsed. So the examples we saw previously were huge, like full lobes, but with PE, it's usually going to be like far out to the periphery and just one part of the lung gets affected. So that's why you have subsegmental atelectasis. You may see something called Westermarck sign, which is basically oligemia. So if you have a clot in the vessel, then you're no longer going to perfuse more distal to that. So then you basically have oligemia. And that's what you see on the right lung field here. You see it's a lot more lucent compared to the left side. And that's what the Westermarck sign is, because they have some like centrally located acute PE there. And this is something else that you may see, which would be bad, which is called a Hampton hump. And that's basically when you have like opacity that's sort of wedge shaped and directed towards the hyla. And that is basically a pulmonary infarct. So that's sort of the progression of if your PE has already resulted in infarcted tissue. So as I said, should I order or not order chest x-rays now that you're telling me a lot of them can be normal? So I said it's very reasonable first line evaluation according to the ACR manual appropriateness criteria. So if you suspect PE and there's like intermediate probability with a positive D-dimer or high pretest probability, then the rating, so these are ratings for like what is most recommended. So it's 1 to 10, 10 is the highest. So 9 is like pretty recommended. This is like radiation exposure, I think. And then, so x-ray is reasonable. You can follow up also with CTA chest with IV contrast. But if you suspect a PE and it's a pregnant patient, it's still reasonable to get an x-ray chest. And then you could consider these other things. So just gonna take this a few seconds to plug ACR appropriateness criteria. A lot of times you're like, man, I really don't know what's going on with this patient. I suspect XYZ, but I'm not sure what imaging will give me, help me reach the answer. So there is this website called ACR appropriateness criteria where you can search up. It's super easy to use. Like you can search by like the topics or like clinical scenario, and it will give you these like tables based on each thing. So this is an example from the like suspected pulmonary embolism. Depending on different scenarios, what imaging would be most helpful to help you answer your clinical question. And it's free to use. You don't have to sign in or anything, just Google it. Okay, lines and tubes. Just keeping this one very short. Just so you know, with the endotracheal tube, the tip should be around 3 to 5 centimeters from the carina. We can measure it for you, or you just see approximately, it's like midway between the carina and your clavicles, which is what these arrows are pointing at, clavicles, carina, endotracheal tube. Why does it matter that it's in the right place? If it's extended too far, you're gonna end up with atelectasis or intention pneumo, and that's actually what you see in this example down below. So this patient, their endotracheal tube was extended way too far. It went into the right main stem bronchus, so then it was just overinflating the right lung, and then what happens, the left lung is not getting inflated at all, so it just collapses. So you have total atelectasis of the left lung. You can also have tension pneumo if you keep on doing this. And then if it's too proximal, you don't extend your ET tube far enough, it can, if it's sitting around where your vocal cords are, it can cause vocal cord injury, or it can affect their patient's swallow function, so they can end up aspirating. So you're just giving them more problems. And if it's the wrong place, it's like totally not even in your trachea, and it's like in your esophagus, you end up just inflating the stomach. So you get gastric dilation, which is not a problem if you just notice it early. And just make sure that the cuff for the tracheus, the cuff for the ET tube is not overinflated, because if you do overinflate, it can lead to like tracheal stenosis or necrosis. Same thing with a tracheostomy tube. It's just basically midline between where you insert it and the carina, which is usually around where T3 is, and you don't want to overinflate it as well. Complications are that you can get tracheal perforation. Central venous catheters, the tip, usually just make sure it's in like the superior vena cava, which is going to be below the carina. So basically, if it's anywhere below the carina, but like not in the right atrium, ideally, then its position is appropriate. And one thing, when you're looking at these chest x-rays, you don't just say, oh, this is central line, because you want to make sure it's like continuous. You don't have any breakage in it or any kinking. And do I have a picture here of that? Yeah. And then some complications that can happen is while placing this, patients can develop a pneumothorax. So this is basically what happened in this picture on the left here. Patient got like a left-sided approach central venous catheter that was placed, and they end up getting a pneumothorax on the left. And you can make out this very vertical line here that's like their lung. And then on this picture on the right here, another complication that can happen is you can see that the central venous catheter, it looks a lot more lateral than it should be. It's not quite in the right place. And the mediastinum is a lot wider than it should be. So this patient had a mediastinal hematoma that resulted from as a complication of the catheter placement. All right, and then finally.
And actually, at this point, I think we'll transition over to Jennifer to talk about the abdominal X-ray, if that's okay.
Yeah, sounds good.
Okay, thank you.
Thanks, Ying. That was great. I learned a lot, even though I'm in radiology also. All right, let me share my slides. All right, we are going to start with the abdomen. So we'll do abdominal X-ray and CT. I am going to be using polls. So we'll try this now. Here's your first question. The question is, I think you should get like a pop-up box for your poll. The first question is, what's your favorite animal? And you only have 5 choices. So you can't like any other animals except these, apparently. All right, that was just a practice round. Here are the results. Apparently 75% of people like dogs. And a couple people like penguins. No one likes bears or bunnies. All right, let's continue. Okay, so here's the outline of the abdomen. We'll start with abdominal radiographs, small bowel follow-throughs, CTs, and then talk about a little bit about what to order. All right, so an abdominal radiograph, there's a bunch of different positions. The first one that we typically talk about is the supine radiograph. So the patient's laying on their back, the X-ray source is above them, and the plate that collects all the X-rays is behind them. So you can see on a normal supine radiograph, you see like bowel gas, you see bones, you can see like outlines of liver and soft tissue. You can also have the patient stand, in which case the X-ray source is in front of the patient and the detector is behind. And here you can notice that like the liver, because it's now up here and based on gravity, it pushes down on the bowel wall. So this is the same patient with supine and upright, and you can see the bowel is now being pushed down because the patient's standing up. And then the last we'll talk about is left lateral decubitus. In this case, the patient is laying on their left side with the X-ray source still in front of them. And the importance of knowing what position the patient is in is that, like Ying was talking about a little bit, air and fluid do different things in different positions. So we'll talk about that more later. All right, so abdominal radiographs are really only good for like a couple things. The first thing is lines and tubes, which is like the most useful thing. Number 2, it can find foreign bodies only if they're radiopaque. Number 3, it's good for like obvious pathology, something that's not subtle. And then 4, we can talk about small bowel follow-throughs a little. So starting with lines and tubes, starting with an approach, there's a bunch of different approaches, just like Ying said. The most important thing is to be systematic and to go through things the same way every single time. So here's just an example of one approach. It's Abdox, which I Googled. You can use this if you find it useful. I kind of simplify that down and think of basically 3 things. I first talk about lines and tubes. I then talk about the dark stuff, which is gas, and then free air anywhere that it shouldn't be. Then I talk about the bright stuff, which is calcifications that aren't where they're supposed to be, and then the bones, and then I talk about everything else. So do whatever works for you as long as you get through it. All right, so we'll start by talking about lines and tubes. There's a bunch of different enteric tubes. This is probably the question we get asked the most, is where's the line or tube on an abdominal X-ray? So the Salem sump has 2 lumens. Typically it's used for like suction, but I think you can also bolus through it. And then you have these 2 down here, Dopphoff and small bore feeding tubes. They can be weighted or not weighted, but these are typically used for feeding and not for suction. So the significance of knowing the 2 types is that they look different on an X-ray. So on image left, you can see this thin radiodense line, and then there's a gap right here, and then you see the rest of the line. So this is the Salem sump or the suction catheter. And then on this image right, you see more like a tube. You see 2 sides of it with the lumen inside of it. And then you can see the tip of it as this radiodense marker that's a little thicker. So this is more like the feeding tube on image right. The significance of that also is that when you're looking at the Salem sump or the suction catheters, the important thing that we'll talk about is where's the side hole. That gap right there indicates the most proximal side hole. So there's a bunch of other holes that are cut into this tube that are distal to that marker, but this indicates the most proximal one. And then when we talk about the feeding tube, the important thing we will mention is where's the tip. Okay, so just for making sure that it's in the right place, you want your feeding tube to be coming down the chest at midline. You want it to pass the carina and not follow the course of the bronchi. You want it to be at midline at the GE junction. And then you want the tip to be beyond the GE junction, beyond this spot. So here it is labeled with what I just mentioned. This would be a pre-pyloric positioning of your tube. You can also place tubes post-pyloric. And in this case, it's exactly what you expect it to be. You want it to be past the stomach. So you want to go past the midline and then over into the right side along the expected course of the duodenum. So in this case, this tip is probably like in the 3rd or 4th portion of the duodenum. This is the question that after someone asks where the tip is located, they'll then ask, can I use it? Just like Ying had mentioned before, I can confirm where the location is radiographically, but I have no idea whether it's working or not. So personally, I feel uncomfortable telling you whether you can use it or not because I don't know if it's working. I can tell you that it's in the tip of the stomach, and based on that, it can be useful for you to know whether it's in the right spot, whether you need to move it, and then you can try to see if it's working clinically. All right, so this is just some practice. If there is a tube here, and I want you to identify where the location is. All right, so as I'm sure you guys saw, there's a line that does not quite make it to the GE junction. And you can see that this arrow is pointing to the side hole. So this is one of those suction catheters. And so this is in the esophagus. This should be advanced further in order to make it into the stomach. Here's another practice. This one might be a little bit more obvious. You can see this line that's kind of coiling around. You can see the side hole marker where there's a gap in the line. You can see that it's in the stomach or projecting over the expected location of the stomach. All right, another example. Here you can see that line is making its way down the esophagus, and then all of a sudden it turns back on itself and it's looped. So this is looped in the esophagus with the tip in the upper esophagus. So that also should be removed and replaced. And then last practice question. All right, you can see this line is making its way down midline, and then all of a sudden at the carina, instead of going past it in the midline, it takes a turn off towards the right along the expected course of the bronchi. And so this is a tube that's in the right lower lobe bronchus. Definitely do not want to use that. All right, so just a few key findings about abdominal x-rays. So this is going to be a poll. Let me launch the poll. Okay, so the question is, what's the most likely diagnosis? All right, I'm ending the poll. Most of you, the majority of you got this right. So this is a retained foreign body. So you can see this loopy thing, this radiodense object, that is not supposed to be there. And that is the typical appearance on a radiograph of a lap pad. So this blue marker is made radiodense by the manufacturer so that in case they leave it in a patient, we can find it by X-ray. So good job to those of you who got that right. All right, this is just a fun case of a foreign body that one of my attendings saw last year. This person, as you can probably find, has these AirPods that are sitting over their right lower quadrant, and those are not external to the patient. So that patient swallowed his AirPods for some reason. All right, this is another poll. So what's the most likely diagnosis on this one? All right, it's a battle. It's a battle between pneumoperitoneum and ascites. All right, I'm going to give you another image, and maybe that'll change what your thoughts are. Okay, so with that other image, this is just an example of why positioning is so helpful. This is a case of pneumoperitoneum. As you can probably tell, this baby was put on their right side down. So the table is over here. And now you can see all of this free air layering, rising non-dependently. You can't see it as well here because this baby's laying on their back, but this dark line, that's kind of like this dark circle that's completely taking up the abdomen, that's all the free air that's coming up to the front of the abdomen. So you can tell how useful lateral decubitus would be if you're worried about free air. All right, here's another poll. Let me launch this. Okay, the question is, what is the name of this sign? I have no takers yet. Oh, one person took. All right, I'm going to take the non-answering as a sign of being unsure, which is good. Okay, so this there's the results. This is the double wall sign. It's also called the Rigler sign, R-I-G-L-E-R. It basically, this is a normal for comparison. It basically, the sign is that you can see both sides of the bowel wall. So if you look at this loop of bowel, you can see both the inside and the outside. Same here, you can see the inside and the outside, whereas normally bowel is up against soft tissue, so you only see the inside of the bowel. You should not be able to see that like thin white line. So that's called the double wall sign, and that's an indication that this person has free air. Okay. So free air, really, really important to try to find on an X-ray, on an abdominal X-ray. Key point is that air rises non-dependently. So think about patient positioning. And then the most common cause, the thing we worry about, is perforated viscous. But of course, if the patient has just gone to surgery, it might be iatrogenic. So here's just a couple more signs. This is an upright film. You can see the continuous diaphragm sign. So normally you cannot see the diaphragm where the heart sits on top of the diaphragm. If you can see the whole thing, that's a sign of free air. And this is the football sign, where the line right here is made up of the falciform ligament, which is supposed to look like the seams of a football. This is another sign of free air on a supine radiograph when air outlines the falciform ligament. And here's the rest of the football. All right, moving on, small bowel obstruction versus ileus. This is probably my least favorite thing about abdominal X-ray. It's a really tough question to answer, and it's because there aren't really great signs on an abdominal X-ray. So on image left, you can see that this is a case of small bowel obstruction. You see multiple dilated bowel loops. You can see these air fluid levels at different heights, kind of at a step ladder. This is suggestive of small bowel obstruction. All the small bowel loops are kind of in the center. You don't see any bowel gas distally. This might suggest the person has an SBO, or clues that the patient might have an SBO. There's also a 369 rule. I put rule in quotation marks because it's a general guideline, but this basically says that the maximum diameter of your small bowel should be 3 centimeters, maximum of your colon should be 6 centimeters, and maximum of your sigmoid and your cecum should be 9 centimeters. So those are just general guidelines for if you want to see if something is too big or not. And then image right shows you an ileus. So here you can see just diffuse gaseous distension of multiple, oh, sorry, there are the lines. You can see diffuse gaseous distension of multiple small and large bowel loops. And then people say that you have these like air fluid levels that are all at the same height, like they're really, really long compared to here where it's like stair-stepped. I don't really know how helpful that is. Honestly, the thing I find the most useful is to ask what's been going on with the patient. So clinical history and exam. And when in doubt, send them to the donut of truth, which is the CT scanner. So there's always a CT if you can't figure it out. So just as an example of how tricky it can be to find an SBO on X-ray, the question for this is there an SBO? Of course, I look at this and I think it doesn't really look like much at all, but then they did get a CT and you can actually see that they did have an SBO on the CT. And the reason you can't really see it here is because their bowel loops are all filled with fluid instead of gas. So if you have small bowel loops filled with fluid, you won't be able to see the contrast between air and the soft tissue around it. And so you won't be able to find it on an X-ray. So that's just an example of why an X-ray may not be the most useful tool for ruling out a small bowel obstruction. All right, small bowel follow-throughs. These are something that a lot of people will order in surgery as management for an SBO. You start with a scout image. You typically have the patient drink 200 to 300 cc's of contrast, which at Vanderbilt, we often use Omnipeg 300. And then you take different images to look for contrast in the bowel. And normal small bowel transit is 30 to 120 minutes. There's been studies that have shown that if you have contrast in your colon at 24 hours, that there's a pretty low risk of having SBO. So here's an example. Here's a scout image. The scout image is obtained so that we can make sure we identify any lines and tubes and make sure there's no contrast elsewhere in the body. We then give contrast, and this image was taken at 1 hour. So you can see now there's contrast in the stomach, there's contrast in a bunch of dilated small bowel loops, but still nothing in the colon yet. So then this patient gets a 5-hour film, and now you can see that contrast has progressed and it is in the colon. So you can see part of the colon down here and over here. And so that this study was terminated at this time, and this suggests that this person does not have an SBO or it has resolved. Okay, the next thing is we'll talk about CTs a little bit. So CTs of the abdomen and pelvis have a bunch of different, you can have contrast at a bunch of different times. So this top left corner shows a non-contrasted study. These are really good for identifying stones, like here, you can see this kidney stone, and they're good for characterizing masses or bleeds. We'll talk about that more in a second. This next image in the top right is an arterial phase image. Arterial phase images are really good for, as you might expect, looking for arterial pathology. They're very good at looking for bleeds, like active extravasation. And then you can also use them to characterize lesions such as an HCC or a hypervascular metastasis. Bottom left is a portal venous phase. Portal venous is the most common, like if you just ordered a CT abdomen pelvis with contrast, you'd get a portal venous phase. It's used for most indications, which includes ischemia, infection, anything, basically most things that you're looking for in the abdomen. It is also the timing that we use for trauma. And then the last one over here is delayed/excretory. So here you can see we've waited for the contrast now to exit basically most of your organs, and it's collecting in the medullary system and the renal collecting systems. So this is really good for looking for a ureteral injury. It can characterize urothelial masses, or you can look at washout of a mass that you've previously characterized. All right, and then we've been talking about IV contrast. You can also give PO contrast, and I'll just mention that there's two types. There's negative PO contrast, which is kind of like gray fluid in color on a CT. And then you can have positive PO contrast, which is basically just like Omni. So you can have them drink contrast so that you distend bowel loops like here, or you can have them drink contrast so you can identify a leak or perforation or something like that over here. All right, so here's another poll. All right, the question is, what would you order in this case of a 30-year-old who has right flank pain? All right, you guys are ready to take care of patients. 100% got that a CT abdomen without contrast is appropriate in this case. And you guys are absolutely right. The clinical scenario is suspicious for a kidney stone, and you do not need contrast in order to find a kidney stone. So here is an example of what you might see. Here's a calcified stone that's in the distal right ureter, kind of just before the ureterovesicular junction. So, and this is without contrast. You can see that there's nothing enhancing. Great job. All right, here's another practice question. The question is a 60-year-old with left lower quadrant abdominal pain. All right, we have a tie between CT abdomen pelvis without and with, and CT abdomen pelvis with contrast. So in this case, the thing that you're mostly worried about is probably like an infection, like diverticulitis or something like that. And you do not need both without and with to identify diverticulitis. You only need a CT abdomen pelvis with contrast. That's important because if you get a without and with, you're basically exposing the patient to more radiation without it being necessary. So the correct answer in this case is a CT abdomen pelvis with contrast. And here's an example of what you could see where this is a contrasted study. You can see the sigmoid colon down here, and this is indicative of diverticulitis. So key point, you do not need without and with contrast in just a typical case that you're concerned for an infection. All right, so most indications in the abdomen pelvis only require CT with contrast, just like we talked about. You can get a without contrast if you're worried about a kidney stone or if the patient can't get contrast, although it will probably be a little bit limited. If you, the reason to order a without and with contrast is when you're looking for a bleed or to characterize a mass or lesion. So you want to make sure that something that's bright on a contrasted study is enhancing, not that it was already bright to begin with. So for most things, you do not need a without and with. And there are just some special protocols. It's probably a little bit different at every institution, but these are just a few examples. For example, a triple phase CT is what we use to characterize liver masses, as I'm sure you've heard before, and that includes an arterial phase image, a venous phase, and then a delayed phase. So this patient gets scanned 3 times at different phases. A urogram, they get scanned 4 times. CTA, they get scanned twice, and maybe a venous phase. So they're just some examples of what we can do with CT. Okay, there's a few things on CT you should probably recognize. The first is fat stranding. So fat stranding basically is this description of hazy white stuff or gray stuff in what is supposed to be clean fat. So you can see that this fat, the subcutaneous and the visceral fat, are supposed to be a nice dark gray. And here you see all this hazy white gray stuff that's surrounding the pancreas. That is fat stranding. Fat stranding is a clue to where the pathology is. So if you see fat stranding, you should look at the structures near it very closely. It basically indicates that there's inflammatory changes. Okay, just a couple more examples of fat stranding. So here you can see that all of this visceral fat is clean, very nice and dark and gray. Whereas by the gallbladder, you see this haziness, this fat stranding. That is an example of acute cholecystitis. And then over here on image right, you see again this clean fat here, but then around this tubular structure in the right lower quadrant, you see some fat stranding. So that's a case of appendicitis. So fat stranding is a clue to what you want to look at. All right, this is another poll. The question is, what should you do next? All right. I guess if you're really hungry, you could potentially eat a sandwich and stat page vascular at the same time, but you guys are absolutely correct. You should stat page vascular, and that is because you guys made the correct finding that there's this huge abdominal aortic aneurysm. And not only is it a huge abdominal aortic aneurysm, they have all of this fluid, this blood in their peritoneum. So this indicates that this aneurysm has ruptured. So vascular needs to come see them immediately. Very important to recognize this. Okay, here's another question of something that you should be familiar with. Here's the poll. And in 10 seconds, I'll give you another image that might make it a little bit easier. All right, here's another image windowed a little bit differently that may help. All right, I love that someone put call radiology. You're always welcome to call us, but maybe call us and then call surgery right after. So you guys, most of you got right that you should call surgery, and that is because you identified this free air. So you see these dark black circles that are not in any bowel loops. You can see it much easier when you set it on lung window, which is why a lot of people will do this. So you can see the free air that is not in bowel loops. And so this is a sign of free air, concerning for possible viscous perforation and without any other clinical history. So you should call surgery. All right, and then another poll, what is the diagnosis here? All right. You guys are correct that hydronephrosis is the correct answer. You can see some dilation of your collecting system over here on the left compared to the right side. You can also see that your kidney on your left is not enhancing as well as your right side. That's what we call a delayed nephrogram. And that was because of this stone that's at the left UVJ, causing upstream dilatation and hydronephrosis and obstructive uropathy. All right, great. If you have questions, feel free to put them in the chat. I'm kind of moving through because I want to be cognizant of your time. We are going to move on to neuro. Okay, here's just our basic outline. There was a question to start about a basic approach to head CT. Again, it's important to be systematic. When you're looking at a head CT, symmetry is your friend most of the time. And I say that because most of the time you can compare one side to the other. And if something looks different on one side, then that's potentially pathology. Unfortunately, sometimes things involve the brain symmetrically. And so you could have something diffuse that's involving basically your whole brain. And so you can get fooled if you're just using the rule that symmetry is your friend. But in general, using symmetry is helpful in the brain. And then make sure that you use all planes. There are some things that are much easier to see on certain planes. So for example, on a coronal plane, it's much easier to look at the lateral convexities. So here and here for any kind of blood or collections. It's easy to look at mass effect or midline shift on the Fox. And then oftentimes your tentorium, which is that flap between your cerebellum and your cortex, your cerebral cortex, you can find blood layering on your tentoria also. And then a sagittal image is really, really good for this image here, which is your midline sagittal. Looking at the midline structures is really best done on a sagittal. So you can see the vermis here, you can see the pituitary well, you can see the third ventricle, you can see the fourth ventricle to make sure they're not enlarged. And then you can see the corpus callosum really well. So very important to use all your planes. When I'm going through a head CT, unlike in the abdomen is all split into organs, so you can just focus on like one organ at a time. In the head, it's not like that. So I do it by pathology. So I first start by looking for blood, basically scroll through a bunch of times and look for anything bright. I then look for hydrocephalus, look at the lateral ventricles, the third and fourth ventricles to make sure they're normal in size. I then look for mass effect or midline shift, anything pushing on something, which might indicate there's pathology like a mass or a bleed. And then the more subtle gray-white differentiation, which is basically differentiating between the cortex and the white matter to try to find if there's an acute infarct or edema. Okay, that's a very basic, quick approach. We'll start by talking about blood in the head. Here is a poll. What is the most likely diagnosis? All right, great job. Most of you guys got that this is an epidural hematoma. So we'll talk a little bit more about that. So differentiating between an epidural and a subdural hematoma is very important. An epidural hematoma looks more convex. It looks like a lens or a lemon, I suppose. Most commonly, it's due to an injury to the middle meningeal artery. You often see an associated calvarial fracture, and clinically, they typically have a lucid interval. Subdurals, on the other hand, look kind of like bananas or a concave shape. They are most commonly due to injuries of bridging veins. They are not often associated with calvarial fractures, and they often happen in older people, like people who are on blood thinners and they fall. They often have subdurals. Okay, so biconvex for epidural and banana-shaped for subdural. All right, here's another poll. What is the most likely diagnosis in this case? All right, great job, guys. So this is a case of intraparenchymal hemorrhage, as you all correctly identified. And talking about intraparenchymal hemorrhage over here on image right, intraparenchymal hemorrhage is just like you expect. It's in the brain, it's in the actual brain parenchyma, and most commonly it's due to hypertension or amyloid. And then you can differentiate that from intraventricular hemorrhage, which is in the ventricles, which is most commonly from hypertension, aneurysm, or extension from subarachnoid hemorrhage. And the important thing to watch for is hydrocephalus. You want to make sure your ventricles aren't getting too big. And then the last one we'll talk about is subarachnoid hemorrhage, which, as you guys know, often presents with the worst headache of your life. Most commonly, it's related to trauma or a ruptured aneurysm. So here's a CTA demonstrating a large aneurysm. If that ruptures, that can cause subarachnoid hemorrhage, where it's kind of like insinuating along all the subarachnoid spaces. And important things to watch for is hydrocephalus or vasospasm. Vasospasm can lead to stroke. All right, so here's just all of the intracranial blood that we've talked about. So you see here they are labeled with an epidural, biconvex, subdural, banana-shaped, subarachnoid, kind of insinuating along all the sulci, interventricular in your ventricle, and interparenchymal in the actual brain parenchyma. And this is just a diagram, a nice pretty picture. All right, MRI sequences. So here are two sequences, and I'm just going to go through them for sake of time. But on image left, this is a T1 weighted sequence. I know it's T1 because T1 is good for anatomy. And if it's good for anatomy, that means white is white, gray is gray. So white matter is white, gray matter is gray. On image right, you have a T2, which the thing most people identify is that CSF is bright. But I want you to also notice that white is gray and gray is white. So key differentiating features for T1 and T2, you can use CSF is bright, but make sure you look at the cortex and the white matter. That's important because it's important to look at the white matter and cortex, because here again, we have T1 where white is white, gray is gray. Now on image right, you have CSF that's dark, but you can see that white matter is gray and gray matter is white. So it's flipped. So this image is a flare. This is a T2 where we have suppressed the fluid. So by remembering that white is white, gray is gray on T1, you will not get fooled on a flare when they pull up just this image. So in a flare, white is gray is white, and CSF is dark. Okay, comparing these two, image left is a T2, just like we've talked about, CSF is bright. Compared to image right, you see that CSF is now dark, and white matter is gray, and gray matter is white. So this is a flare, not a T1. All right, on image left here, we have a T1 pre-contrast. If you scrolled through, you'd be able to see the same thing we've talked about of white matter being white and gray matter being gray. And notice the nasal mucosa is kind of this gray, darker gray. On image right, now you can see these bright areas lighting up around the brain. And you also see that the nasal mucosa is bright. So this is a post-contrast T1 versus a pre-contrast T1. Things to look for on a post-con to know it's post-con. People like to say the nose knows in neuro. So that means that nasal mucosa enhances. And then you can also look for vessels like here. All right, and then I think this is the last couple that we'll talk about. Image left is a DWI and image right is ADC. I look at these and I think they look like really poor resolution. They just don't look like great images of the brain. You can see that like you can't really see the scalp and like bone very well on either of them. Like here, it's just this like grid of like black and white. So that's how I differentiate, like when I'm first looking at something, whether it's DWI or ADC. So poor resolution for a DWI, and then on ADC, it's basically just the inverse of a DWI. So you have bright fluid and even worse resolution to my eye. In order to find restricted diffusion on a DWI, you are looking for something bright on DWI and dark on ADC. Okay, so here's all of them together. So we'll just go through them. This top left corner is white, gray is gray. So that's T1. This middle, CSF is bright, white is gray is white. That's T2. Top right, white is gray is white, and CSF is dark. So that's a flare. That is just, a flare is just T2 with fluid suppressed. Here you can see vessels that are bright with white is white, gray is gray. So this is a post T1. Here you can see a pretty crappy resolution image with fluid that's bright. So this is an ADC map. And then this is a pretty bad resolution study also with dark fluid that is DWI. All right, this is just, you can go over this on your own time. It's basically what I just said in words. So you can look at that yourself later. All right. I guess we'll just do a couple polls. It's getting a little short on time, so I'll just do a couple for your practice. Here's a poll. I want you to name that sequence. Excellent. You guys crushed it. This is a flare. So notice CSF is dark, but don't get fooled that it's a T1 because white is gray is white. So this is a flare. Excellent. All right, we're not going to pull this one, but I want you to take a second to think what sequence this is. All right, this is ADC. As you can see, this is a really crappy resolution study. You've got this kind of like rim of gray-white pixels. You can't really see any soft tissue around the brain, and CSF is bright. So this is ADC. And then this image, we also are not going to use a poll for now. For this image, you can see that the nasal mucosa is very bright, and you have vessels that are also bright. So this is a post-contrast T1. This is the saying the nose knows. All right, we will move on to stroke. So we will pull this one. What is the initial imaging of choice for if you are concerned about a stroke? All right, the poll should be up. Excellent. You guys are doing great. So you all are absolutely right that the first imaging of choice for a stroke is a head CT without contrast. And just think to yourselves, what's the main purpose of getting a head CT without contrast? So the main purpose is not really to identify the stroke itself. Head CTs are actually very not sensitive for identifying strokes, but the main purpose is really to find blood or any other pathology that could be causing the patient's symptoms. Mostly blood, because if they have blood, then they can't get TPA. All right, so the stroke protocol, at least at Vanderbilt, when someone gets called a code stroke, when someone calls a code stroke, they get a CT perfusion study. A CT perfusion study has 3 parts to it. The first part is a non-contrasted head CT. The non-con head CT, just like we've talked about, it's to rule out an intracranial bleed. So you're looking for anything bright, like we talked about before. You can also find several signs of a stroke. So for example, you might see a hyperdense MCA. This is a non-contrasted study. So this bright MCA is abnormal. And this basically suggests that there's thrombus in the MCA. This is not something that you see all the time, but if you find it, you can, it is suggestive of a stroke. The other finding you might see is an established infarct, something that's been going on for a little bit of time already, where you start seeing this hypodensity involving most of the left MCA territory here. All right, so that's part 1, you get a non-con head CT. Part 2, you'll get a CTA head and neck, and that's to look at vascular anomalies. So you'll get to see all the vessels very well, so you can look for aneurysms, stenoses, anything like that. You also can find large vessel occlusions. So in this case, you can see that there's an abrupt cutoff of the left MCA. So this is someone that might go to surgery where they can take out that thrombus. So that's why we get the CTA. And then part 3 is this perfusion portion, which is all the colorful pictures that you get. There's a bunch of different parameters that we use. CBF is cerebral blood flow. CBV is cerebral blood volume. And MTT is mean transit time, TTP is time to peak. The important thing I'll show you on the next slide. So basically perfusion helps to identify whether there's dead tissue or whether there's tissue that you can potentially save. So there's a bunch of different imaging softwares that can do this. At Vanderbilt, we use this thing called Rapid. Yours might look similar to this or slightly different colors, or I don't know. But basically when you look at this map, this image left shows you cerebral blood volume flow less than 30%. There's a volume of 25 milliliters of brain tissue with that parameter. And this indicates the core infarct. So everything in pink is dead tissue. It is not salvageable. Image right shows you this green area that's much bigger that involves the same area as the pink. This suggests that this is at risk. This is tissue that is ischemic but not infarcted. And the difference between these two, 283 minus 25, gives you the mismatch volume, which people will say is your penumbra. So that is the potentially salvageable tissue. If you were to go in and intervene, you could potentially save all of the green minus the pink. So using this number, neurosurgery will then decide whether they want to do anything. Okay, just as an example, here is on image left, this is DWI. Notice you cannot see any of the outside soft tissues. This is ADC, where CSF is bright. And then this is a flare. Notice white is gray is white, CSF is dark. So you can see this area of bright intensity on DWI, it's dark on ADC, and it is not bright on flare. So this is suggestive of a right MCA territory infarct. All right, this is just a review of cerebral territories. So you can see the PCA is back here in the occipital lobes. You have the ACA, which goes along the strips of your falx, and then the MCA on both sides of your temporoparietal lobes. All right, and then just a quick overview. I think you'll probably get these slides or it's recorded so you can pause it, I suppose. Things I really want to point out, a head with contrast is not really that useful. If you're thinking about getting a head with contrast, just get an MRI. Unless your patient cannot get an MRI, heads with contrast are not really that helpful to us. And then the other thing so most CT heads are without contrast, unless you're getting a CTA or a CTV. And then most necks are with contrast. So most of the time you'll order a CT neck with contrast. And then most of the time, if you want to look at the head, you'll look at a CT head without contrast. And then MRIs, if you are going to give contrast, you are also getting it without contrast. So if you're getting a head to evaluate mass, infection, pituitary, anything like that, you would get it without and with contrast. And the neck, same thing, without and with contrast. So it's different than a CT. And again, a little plug for the ACR appropriateness criteria, which can help you make decisions. I'm going to skip through this because of time and I want to be aware of your time. Here's just an example of the tables, kind of like Ying was showing before, of headache and neck mass. But this is on the ACR appropriateness criteria tables. All right, 3 minutes to spare. If there are any questions, I'm sure that was a lot. You guys are all going to do great. But if there are any questions, feel free to ask us now or email us. We're happy to help. But thank you guys for listening. I hope you learned something.
Yeah, if you guys don't mind dropping your emails in the chat so that potentially we could reach out with questions.
Thanks a lot, Jennifer and Ying and John.
There's one more thing. I'm going to be sending a link for a feedback survey. Please fill it out so that we can know what we did well, know what we need to improve on. And thank you guys so much for attending.